Our summer bundle was supposed to end, but after hearing from so many moms who said, I meant to sign up, I've decided to extend it for a few more days. So you can still join My Essential Birth for just $197 and receive all 3 bonuses: the Birth Partner Quick Reference Guide, Belly Mapping Guide, and Empowering Birth Meditation Chat. If you're ready to feel more confident, prepared, and empowered for birth, now is the time. But don't wait. This extended offer ends June 24th. Visit myessentialbirth.com/get started, all one word, and join today.
If your parents had type 2 diabetes, you're at an increased risk of type 2 diabetes and gestational diabetes. I mean, it is a lifestyle disease, but there's some genetic components that go along into it. If both of your parents had type 2, you're at a 50% chance of developing type 2 diabetes yourself. Babies who are born to mothers. So even if your mom doesn't have type 2 diabetes, but had gestational diabetes in pregnancy with you as the baby, you're at an increased risk of developing gestational diabetes and type 2 diabetes.
Getting pregnant and giving birth are 2 of the most exciting things you can ever hope to experience in this life. The moment you think you could be pregnant, you're frantically searching for all the best information, which is why you're here today. I'm Stephanie King, and with my many years of experience as a professional childbirth educator, doula, and lover of all things pregnancy, birth, and postpartum, I'm here to make preparing for your birth enjoyable, empowering, and totally easy. Each week, I'll cover different topics, interview professionals, and get into the nitty-gritty birth stories from mamas just like you. And when you're ready for more, you can join me in the My Essential Birth course at myessentialbirth.com, where I take you step by step through exactly how to prepare your mind, body, spirit, and partner for a birth you love. So let's get started. All right, you guys are in for a special treat today because I have here with me Bonnie and Karina. They are midwives in Davis County, Utah. They're also really good friends of mine. So when I got into birth work and I started teaching classes and I started doulaing, these are the wonderful women that I got to hook up with, and they have completed their journeys and continue to serve the women in their area. And they're both now midwives, which is amazing. So with that, Bonnie and Karina, say hello. Tell me just a quick intro about yourselves, and then I want to dive into today's topic, which is all about gestational diabetes.
My name's Bonnie Baker, and I am a midwife. I've been a birth worker since 2014. I started as a doula, childbirth educator, and just gradually worked my way up. And I started out my journey as a doula with Stephanie.
I'm Karina. I am also a midwife. Similar backstory to Bonnie's. I started out as a doula, and after having kids of my own, and then just continued on to become a midwife. I also have type 1 diabetes. I've had it for over 35 years. So yeah, it's kind of special to me.
Yeah. So I'm glad that you're both here because you are wonderful people to have on the topic. On top of loving women and all of that, Karina, I think you have some really personal experience that makes it just that much more interesting and helpful for women to hear from you. So with that, let's kind of dive in. What is gestational diabetes? As midwives, kind of what do you guys see? And just take us through what it looks like for you guys to work with women who have gestational diabetes.
I think we actually get a higher percentage in our practice of women who have gestational diabetes because of Karina's expertise. I will joke, but also not really joke, that unless the endocrinologist or doctor that someone is seeing has more than 35 years of experience, then Karina knows more than them, because it's something that she lives with every day. Karina, hopefully you don't mind that I'm kind of putting you out like this, but it's something that she lives with every day, and it's not something that she gets to clock out from like a job. And so she's the expert. And I tell everybody, if they've come in because of a previous pregnancy with gestational diabetes and their midwife, transferred their care to a hospital because they didn't know how to manage it, or if it's their first baby and they end up with gestational diabetes, I tell them that they're in such good hands because Karina is on it. She knows all of the tricks. And I have a background in nutrition and working with older population with type 2 diabetes, but really, like, Karina is one that knows her stuff.
Okay, well, let's talk a little bit about what gestational diabetes is then. And gestational diabetes is different from the type 1, right? So type 1 is something that you're born with. You don't necessarily have it. You can't do anything about that in the way of controlling it in any particular way other than with insulin. So what's the difference, if you want to talk about that, type 1, type 2, and how that looks for women who have gestational diabetes during pregnancy? Maybe you guys can talk about what's happening on the inside and then how you guys choose to test for it, what you like and don't like with testing, and we'll kind of go from there.
So type 1, you're not necessarily born with it. You can develop it. I got it when I was 4. It's where your immune system attacks the cells from the pancreas, and so it kind of kills off the pancreas, essentially. So it doesn't work anymore. Type 2 is insulin resistance that can become so bad that it requires medication. And a lot of the people who do require medication, being type 2, go on to need insulin it can be a lifestyle thing. So if they don't get that under control, then it can go on to require insulin. And then gestational diabetes is the placenta and pancreas kind of getting in a fight during pregnancy, and creating more insulin resistance.
Bonnie, did you want to add anything to that?
No, I think that Karina covered that really well. I guess maybe my only addition is that there are certain things that can make a person more at risk for developing gestational diabetes in their pregnancy than others. And so that's something that we actually pay attention to a lot as well. If someone comes in and reports that they have already have like a pre-existing metabolic issue like PCOS, for instance, that in and of itself is actually an insulin resistance disorder. And we know that if we have someone who has a baseline that's already at a higher risk for insulin resistance, we're going to check that mom, get her on a good protocol if she's not already on one, because we know that her risk is elevated. And we also know that their risk is elevated for not only just for developing gestational diabetes, but also preeclampsia. And there is a relationship between gestational diabetes and preeclampsia. They almost go hand in hand. So it's something that if we have one, we almost always have the other. And if we have someone who has preeclampsia, we will kind of retrospectively look and say, was there anything that indicated insulin resistance, or was that a standalone case? Because they are so incredibly common.
Yeah, I think what's interesting in that I took a nutrition thing probably 2 years ago now, and the woman teaching it, and she was talking about insulin resistance specifically, talked about PCOS. And she's like, PCOS is diabetes of the ovaries. And I love that you brought that up because not everybody gets that connection. I hadn't heard that until she said it. And she wasn't even involved with pregnancy and birth and the uterus and all that area. Hers had to do with like weight loss and nutrition and all that kind of stuff. So I thought that was pretty interesting. And it would make sense that it would go hand in hand with that. If that really is true, if it's an insulin thing from before you were getting pregnant, and that's not corrected when you go into pregnancy, then yes, you can create more of an insulin issue being gestational diabetes as you continue. And I think too, what's really interesting, and I'd love to hear your guys' protocol, is that gestational diabetes much of the time can be managed with our diet. And it actually made me wonder, as you're talking about more women coming to you with gestational diabetes. And I do think that there is something to say about that because of Karina's expertise. And I do think, honestly, that's just how things work sometimes, that's how people get hooked up. But I don't know if you guys are noticing it, but diabetes in general, particularly type 2, is on the rise everywhere, particularly in the United States right now. And my concern with it, being a childbirth educator and doula, and you guys working with pregnant women, is that it's going to put women into a risk category that doesn't allow them to have options for their bodies when it comes to pregnancy and birth. So that's like top of the list for me, why it's such an issue. Not just that, but then what is that doing to our babies and what, the postpartum and motherhood and all that's going to look like. So maybe can we talk about that? Gestational diabetes specifically. I want to talk a little bit about the nutrition side of things and how you can manage it. I want to hear about your protocol. And you talked about different testing that you guys like and testing that you might not like as home birth midwives. And so if you will share a little bit about that too. If birth is getting closer and you're still feeling unsure about how to prepare, this is for you. My Essential Birth gives you a simple, step-by-step roadmap to prepare your mind, body, and birth partner for birth so that you can stop wondering if you're doing enough and start feeling confident about the big day. And right now, you can still save $100 and receive all 3 amazing bonuses designed to help you feel even more prepared and empowered. The Birth Partner Quick Reference Guide, Belly Mapping Guide, and Empowered Birth Meditation Track. But this extension won't last forever. Join us by June 24th at myessentialbirth.com/get started and start preparing for a birth you'll love.
So we like to test using a glucometer or even a CGM and have them a continuous glucose monitor and have them record everything that they eat, what the times that they're testing, so we can see if anything that they're eating spikes their blood sugars, or if it's a time of day thing, so that we can narrow it down to figure out the culprit and kind of fix that.
Also, too, there's been a lot of studies that have shown that CGMs are actually catching more instances of gestational diabetes than a glucometer or the OGTT, the oral glucose tolerance test. We'll use that one as well if somebody doesn't want to poke their finger or doesn't want to wear a CGM for a week. We still support them if they wanted to do the fresh test or just the standard, drink from the lab. But those have the most, the highest rates of correct research showing accurate diagnosis is I guess what I'm trying to say. We hear about people that eat jelly beans or eat a handful of Twizzlers or drink a soda and eat a fruit leather or have pancakes for breakfast and an orange juice and then get their test done. And there are so many people that it misses with those. Those are wildly inaccurate. And so we do not support those type of tests. If we have someone coming to us saying that that's the type of test that they want to do, we'll have a conversation with them and explain to them the rate of misdiagnosis or underdiagnosis with those tests. And usually after that conversation, they're like, oh yeah, no, I really don't want to do that actually. And so the candy bar test, what are some of the other ones that we've heard, Karina? A1C, that's terrible. It doesn't really give us an accurate picture.
Smoothies.
Random glucose tests also don't work.
We had one client who opted for the glucola test, and she came back as screening positive for gestational diabetes. And so we had her take home the glucometer to see again what is spiking her blood sugars. And she just doesn't eat like that normally. And so when she brought back her results from the glucometer, she does not have gestational diabetes at all. So even some of the people who screen positive for the glucola, when you're not consuming that much glucose at one time, it can cause a false positive.
Yeah. And that makes sense to me that it totally could. And I know that I've seen that as well. It's interesting as far as the testing goes, because I think the big thing with women wanting to do something maybe not particularly jelly beans, but pancakes or a banana or a smoothie or something like that is because the glucola drinks are so disgusting and they have stuff in them that you're like, I don't want to put this in my body when I'm pregnant. I don't normally do that. Why would I do that? And so when the fresh test came along, I actually had the woman that created it. I had her on the podcast because I was like, this is so neat. This is so interesting. If you're going to require this test, then yes, this has the exact amounts that you're looking for. But always my preference is to have someone doing what you're talking about because it's the best way to monitor it. That's how you're actually eating. That's what your body is actually doing during the day. And so if you're willing to do the testing, then I think it's the most accurate way to test that. So that's awesome. So say that you have somebody that does pop a positive and yes, we're dealing with gestational diabetes. What do you recommend to them? What's the protocol? What does the nutrition look like?
Nutrition, what that looks like is, so we want to be gentle in our approach of, helping them adjust their way of eating. And I'll tell you that every person that we've had who has been compliant, they've been on board with this plan, we've had really successful, wonderful outcomes. I would say that babies born to moms in range have the same outcome as babies born to moms who do not have gestational diabetes at all. compared to babies who are born to moms who are out of range for their numbers. They are at an increased likelihood, as well as there's because gestational diabetes is on the rise, it is affecting us generationally. And yeah, it is a problem. So, but back to nutrition, we start off gentle. We really put an emphasis on protein, removing some of those simple carbs that are just going to spike people. A lot of times people also think that it's just sugar, and that they like, oh, well, I can't eat candy anymore. I can't eat sugar. I can't drink soda. And the answer is correct, but also it's about carbs. Diabetes is about carbs. And so we're looking at their carb intake. We don't want them to go too low, but we're looking at their carb intake. We're reducing the amount of simple carbs that they put in. And I tell people, if you focus on getting your adequate protein, minimum of 100 grams of protein a day, if you're getting your healthy protein sources, if you're getting your healthy fats, if you're getting colorful vegetables, your carbs are going to fall into place. You're not going to have to worry about it. We have really enjoyed seeing what a CGM does for people, because we can also look at what their overnight blood sugar does, and that matters a lot. Fasting blood sugar matters. I don't know if you want to touch on that, Karina.
Yeah, fasting blood sugar actually is the component to make for macrosomic babies. So it's the high blood sugar overnight, staying high into the morning, creates those bigger babies than the ones throughout the day. The studies have found. So.
If we see that someone has high blood sugar at night and that's what's causing the high fasting, then we're going to work with them and counsel them on how to adjust maybe their diet at the end of the day, a bedtime snack, something protein based that can help them stabilize their blood sugar throughout the night so that their fastings are normal. Or sometimes we have people who dip down and then spike back up in the morning. So then we will also work with them on it's usually a bedtime snack. Sometimes it's a middle of the night snack, but adjusting so that we've got numbers in range. And everybody that is excited and wants to be empowered about their health in our care, they've always done so well. They've always done so well.
We have a lot of people, the ones that do the CGM or even the glucometer, they're like, this is so cool. I want to continue this after pregnancy because I'm just learning so much about my body. So.
Yeah, I think that's kind of the missing link sometimes, is for, especially with women with just your everyday provider, particularly in hospital providers that don't have any kind of continuing education or knowledge on the nutrition side of things. I think that's such a disservice that we're doing to women to not give them that information up front, to not only prevent things like gestational diabetes, but to treat it properly when they have it. Instead of what I have heard, which is crazy to me, is a provider saying there's really nothing that you can do. It just one in however many women are going to experience this. So we'll just take it as it comes. And if we need to, we'll talk about insulin. And I'm like, that is so wrong, because you actually you can have a big effect. If it's this type 2, if it's gestational diabetes, nutrition can have a huge effect and you wouldn't need to go on medication at all, which really, again, keeps you in the driver's seat of all your decision making during the process. So I think it's so important that I love that Midwives is just naturally part of what we do, right? It's like that holistic view of the entire body throughout a pregnancy and birth. So yeah, it's lovely.
I think that also it's important for people to understand, and this is something that we'll talk with our clients about in depth, is that this is almost like an opportunity to change things in their life now, because it is a little bit of a warning sign that person has an increased chance of developing type 2 diabetes down the road. And if we can make some lifestyle changes now, we can avoid that, or we can prolong that diagnosis. Maybe it's not necessarily something that we can completely prevent, but we can extend their health a little bit further before that diagnosis hits.
Yeah, you guys kind of mentioned, I just want to go back to this. You kind of mentioned the placenta and pancreas getting into a fight. Will you go a little deeper into that and tell me what you mean?
If you have a stressed out pancreas to begin with, right, if they're at an increased insulin resistance to begin with, then we know that the hormones of the placenta are already going to stress out the pancreas further. But there are even someone who has a healthy, normal pancreas prior to pregnancy, the hormones can still affect the way that the placenta and the pancreas, or the hormones from the placenta can affect the way that the pancreas reacts and manages insulin. We do expect to see a little bit of a spike in the beginning of pregnancy with glucose because of how hard our body is working, but it's minimal. It's not something that's going to cause high blood sugars, like fastings or postprandials, which is postprandial is like the 1 hour after breakfast, lunch, and dinner that we're looking for. If we have someone who has a higher A1C at the beginning of care, that tells us an A1C, hold on, I'll pause. An A1C is an average of the last 3 months, what their blood sugars have been doing in the last 3 months. So someone can have a normal A1C in the beginning of care and still end up with gestational diabetes. So that's why we also say that that's not an accurate marker for gestational diabetes or the risk of developing it even. Because around 28 weeks, the hormones of the placenta really kick into high overdrive, and it can affect the way that the pancreas is managing the glucose load. And if we have an already stressed out pancreas, it's just going to shoot up. We're going to have issues. So that's kind of what we mean by like they get into a fight. They disagree with each other. They don't get along. And also we know that there's a lot of research in the sperm qualities, the health of the dads, affecting the placenta. So it's not just about mom's health. It really is not. It's about both partners' health in preconception. And that can affect the mom's pancreas as well, which is really a fascinating thought.
So I feel like moms that are listening right now, if you plan to have more children, like have dads listen now, so that you can prepare both of your bodies for the next one, Yeah. Okay. For moms that are listening. Okay. So do you do this during the testing? Do you do your CGM and looking at those numbers at the regular time that somebody would typically test, like that 28-week-ish mark? Or yes, that is when you guys do it?
Yeah. Mm-hmm. Yeah.
Yeah.
Okay.
Yeah.
What signs and symptoms can moms look for coming up to that, or whether or not they tested positive or negative? What are some of those like telltale signs that a mom is experiencing gestational diabetes and she should have it looked into?
Unfortunately, gestational diabetes doesn't have a lot of symptoms because it's a really quick onset. It's the ones that do have symptoms they're like pre-gestational diabetes. So like type 1 or type 2. Those are the ones that would typically show symptoms versus gestational diabetes.
In clinic, in an unmanaged gestational diabetes situation, clinically, we would see fundal height increase rapidly. We look at it starting at 20 weeks. It should match their gestational age with give or take 2 centimeters. So if, 20, 24 weeks, they should be 20, 24 centimeters, right? Like at each of those appointments. If we start to see them starting to increase at 28 weeks, maybe they're measuring 30. At 30 weeks, they're measuring 34 and then 36. And they're just starting to jump ahead. That tells us that we might have a baby who's been getting a lot of sugar in their system. There's a correlation between gestational diabetes and increased fluid, amniotic fluid. So clinically, we start to see things in an unmanaged situation. I don't think that we personally have a lot of unmanaged situations because we are so passionate about testing, but those are clinical signs. And then also it stresses out the body. So we can also start to see elevated blood pressures, people starting to have protein in their urine, their liver and their kidneys are getting stressed out and showing signs of preeclampsia. So those are all signs. But it's more towards the end of pregnancy. Like Karina said, you're not going to notice a ton of symptoms in the beginning, but clinically it's going to show itself if someone has declined the gestational diabetes screen. It's going to present itself with some other clinical symptoms.
Karina, did you have anything you wanted to add to that?
Yeah, you had asked symptoms for like type 1 and type 2. So for high blood sugar, that'd be like having to pee a lot, which pregnant people already do. Um, being tired, again, pregnancy. Let's see, being really thirsty, wounds healing slower, things like that.
Okay. Yeah. Which, as you're like saying all of that, minus maybe the wounds healing slower, I'm like, yeah, how do you, like, how can you tell if I'm just pregnant or if this is something, that has to do with gestational diabetes? That's kind of funny and terrible
Exactly.
all at the same time. Okay. How about providers that are like, or I guess not providers. How about even women who are like, I don't want to do the test. Like, I'm good. I don't need all the extra testing for all the things. And they just feel like I don't want to do this. And in fact, maybe they're like, I eat really well. I get high protein. I'm not worried about this. What do you say to them? What is your recommendation?
So we explained the reason why we're so passionate about it, why it is important for pregnancy, and kind of because I think a lot of people are like, oh, well, I'm fine. I don't have any symptoms, right? I don't have um, like anything in my family, but it is an important test to do. And so we explain the reason why and the risks of not doing it. And if they still don't want to do it, then that's their choice, but we are not the provider for them.
So there is a very small window of women who meet the criteria for declining the GDM screen and not being at risk for it. But if the risk factors for gestational diabetes include being over 25 years old, African American, Asian American, Latino, Hispanic American, Native American, or Pacific Islander, having a BMI of over 25, history of abnormal glucose tolerance or macrosomia, so a big baby, diabetes in a first degree relative, so your mom, your siblings, right? Your dad, not physically active, a previous pregnancy with a history of a baby that was bigger than 8 pounds, 13 ounces, or 4,000 grams, depending on where you live, a previous pregnancy history of stillbirth or miscarriage, previous pregnancy history of hypertension, high cholesterol, high triglycerides, history of PCOS, preeclampsia, or cardiovascular disease. So if someone can say no to every single one of those, then they are a candidate for someone who could decline that. Unfortunately, that's something that we see very, very rarely. Very, very rarely. It's interesting that pregnancy loss puts you at an increased risk of developing gestational diabetes in the next pregnancy. Yeah. Mm-hmm. Yeah. It's interesting that we do not have very many people in our society now who can say no. They do not have a first degree relative who doesn't have gestational diabetes, or excuse me, a risk of diabetes, any type of diabetes.
Right.
If your parents had type 2 diabetes, you're at an increased risk of type 2 diabetes and gestational diabetes. And it is a lifestyle disease, but there's some genetic components that go along into it. If both of your parents had type 2, you're at a 50% chance of developing type 2 diabetes yourself. And so like we absolutely want to test those women. Babies who, we talked about this before, babies who were born to mothers. So even if your mom doesn't have type 2 diabetes, but had gestational diabetes in pregnancy with you as the baby, you're at an increased risk of developing gestational diabetes and type 2 diabetes.
Yeah, which is something I think for moms to think about, as we're preparing to get pregnant and have these babies ourselves, that what we do to our bodies directly affects our babies, just as it was for our parents. And so just good information for us to be as healthy as we possibly can for these little lives that we are creating.
And, on that note too, gestational diabetes also increases risks. And this is more unmanaged, okay? When we talk about the risks, we're talking about unmanaged gestational diabetes. Outcomes for women who have really tight control are just about the same as not having gestational diabetes at all. So when we talk about it, we're talking about unmanaged gestational diabetes, or any type of diabetes, I guess, really. Um, but there's an increased risk of having a birth defect, miscarriage, stillbirth, preeclampsia, big babies, which is kind of like, I think the main thing that people focus on is like, oh, your baby's going to be giant, or you could have a shoulder dystocia. Yes, but also we're talking about placental insufficiency as well. If your body is stressed out, it's also going to stress out the placenta, which is going to cause issues with baby. If you start to develop preeclampsia on top of it, your body's working really, really hard to try to push all of that blood flow into a placenta that's not processing that blood flow well. And that's kind of where that increase in blood pressure comes from. And, that affects us now in the pregnancy. And it also affects our baby's future pregnancies, our daughter's pregnancies as well. That's heavy when we think about it like that,
I know. Well, and when you think about like that, when a female baby is born, that she's born with all the eggs that she will ever have to give birth to her babies. So yes, everything that is happening in utero is going to be transferred on to that baby and all of her future babies, which is, yes, a lot of pressure and a lot to think about for sure. Will you talk a bit just for a moment about like macrosomia or these bigger babies? And I don't know, you said, with managed gestational diabetes, it sounds like this isn't maybe that big of a deal, but say that you're seeing those fundal heights and at 30 weeks, they're at that 34 rate or something like that. You talked about an increase of water and a bigger baby. So what are the risks for mom and baby with maybe the increase of water and those bigger babies as we're talking about giving birth, especially out of a hospital setting where you guys do home birth and birth center?
Yeah, so shoulder dystocia is a big one with big babies. I've seen a lot of people, care providers in hospital, will recommend a cesarean for big babies, especially to people who have diabetes of any kind, because their babies do tend to get bigger in the abdominal area, not so much so they have like smaller heads, but because they're fatter and have bigger bodies, so they tend to get stuck. And so I've seen a lot of them recommend just like straight to a cesarean for a big baby in hospital. Um, in our practice, we want managed diabetes, gestational diabetes. So if they can't manage it, then we would risk them out of our care.
And Karina, isn't it correct on cesarean that we're at like a 25% increase, or excuse me, we're at a 25% chance of having a cesarean in just a normal low risk pregnancy. But with GDM, we're at like a 40% increased risk of a cesarean.
I think so, yeah. I think those were the
in an unmanaged GDM. Mm-hmm. And it's like 45% with type 1 and type 2, right?
Mm-hmm. And then with excess amniotic fluid, you do have the risk of like cord prolapse if the water breaks, and then babies being in a weird position, like breech, and because they have more room to move around. So
Okay. And so the pregnancies that you guys deal with and these managed babies, even if somebody comes to you with GDM, it sounds like not much changes. If they're able to manage, the birth goes on as normal. The babies, maybe even if they're growing big, are still manageable as far as labor and birth goes. Is that correct?
Yeah, there is more monitoring in labor too, because we want them to be in range, and then we do test baby after birth as well. So there's more monitoring as far as labor and delivery,
and it's also one of the things that we do for monitoring is we're looking at mom's blood sugars within 3 hours of birth, which we don't know necessarily when that's going to happen. So if we think we're getting closer, we're going to start, checking their CGM more often, or we're going to, maybe do like a quick finger poke if we think we're like getting closer to pushing, because the 3 hours before baby's born is really important for their blood sugar. If mom's high, there's a risk of baby going low. And if mom's low, there's still a risk of baby being low. So we want moms in range. There's also an increased risk of hemorrhage with gestational diabetes too. that I think is quite a fascinating thing that I don't know that providers necessarily correlate. And in an out of hospital setting, we have to think about all of these things. We can't just hook a person up and just open up an IV and run PIT full force the way that a hospital can. So with a well-managed gestational diabetes, birth and delivery, we're good. If there's unmanaged issues, hemorrhage, shoulder dystocia, you're also at increased risk of a hemorrhage right there too. So like, why double up your risk factors in an out of hospital setting and have something unmanaged and then have a hemorrhage on top of it, and a shoulder dystocia? Why make more work for yourself?
Yeah. Okay, so what would you guys say that you want moms to know just more than anything going into pregnancy? And if they're pregnant now, preparing to have a baby later on or take this testing or anything, what do you want them to know?
I'll go first, and then Karina, I want you to add your part as well. But I have a saying, and it is that nutrition is the trunk of the tree of health. And maybe I've said this on your podcast before, but it really is. So many complications can be mediated or forestalled with good nutrition. And starting in the 3 months prior to conception or the beginning, like any time is the right time to start, to be clear. Starting to eat healthy can happen at any point. You're not too late to start eating healthier. But ideally, if you can start in that 3 months, the preconception trimester, just focus on protein and colorful vegetables and healthy fats, and everything else is going to fall into place. And if you do have a diagnosis, it doesn't, as long as your provider is comfortable with GDM, it doesn't risk you out. You can still have a really healthy, normal birth if your provider knows how to help you manage it.
If you do screen positive for gestational diabetes, that is not the end of the world. There are things to manage it. There's, we know a lot more now. So there's like supplements, nutrition, there's a lot more available to help. And I hear a lot of people be like, well, I'm glad that I'm done poking myself after being pregnant, right? I don't have to do that anymore. But if you keep going the way that you were going, you will have to do it because you're going to get type 2 diabetes. So it is a good wake up call. And just knowing that like I can get control of my body now and I hopefully won't have to do it forever.
Okay, is there anything I didn't cover that you guys want to make sure and discuss before we jump off?
I think it's super important that people know that they should be tested postpartum if they had preeclampsia and gestational diabetes and PCOS, obviously. They should be screened postpartum for type 2 diabetes. That is in all of the literature. However, I don't think people are doing these things.
Yeah, I haven't heard of it for sure. So I'm glad you said that.
And then I guess just exercise, like staying physically active. And you don't have to go crazy. Like just go on a walk every night. Do some squats, right? You guys were both like the squat queens for your pregnancy. Steph, I remember you talking about just like squatting while you're waiting for like your water to boil when you're making dinner in the kitchen when you were pregnant. I remember hearing that story and just how you like increased your squat time that you could hold your squat. That like just stay active, just fit it in like the little spaces, because that also affects your blood sugar as well.
Yeah. In fact, they've been able to show. So if you go for a walk after you eat, like just shortly after you eat, like 15, 20, 30-minute walk, or you do like 40 squats, like either of those things will decrease your insulin and quite quickly too. So it helps totally stabilize your blood sugar. So I totally agree with that.
Kind of funny because we put a CGM on my son because we were thinking that he might be having some blood sugar issues. And when he would go high after having, of course, like sugary cereal, right? Where I'm like, do 15 jumping jacks. And he would do it. And like within 5 to 10 minutes, it was like going back down. And it was just like 15 jumping jacks. That was it.
Yeah. Well, and isn't it funny that exactly how our bodies were created, if we use them that way, if we listen to our bodies and we use the functions of our bodies properly, that it naturally takes care of itself, right? We're constantly striving for that state of homeostasis. So it makes sense that our bodies would tell us to do, like little kids, it's so easy for them. That's why they don't have an issue a lot of the time early on, because they're young. And even when they have those things, they're the movement and all the, like what your body naturally does, like they're just burning at all times. And then, we get older and lazier and just less movement and more sugar, and it just piles up over time. So, and then pregnancy, I feel like it's just not the time to mess around. That's when you really want to just be at your peak health for yourself and future children. So awesome. All right. Well, thank you both for being here. What a neat conversation. I'll definitely link all the places that people can find you. But before we jump off, do you want to just tell us your Instagram and where you're located in Davis County? If you guys are in Utah and you're anywhere near Davis County, these are your midwives. Please go to them. They are, just if I were pregnant, and I told Bonnie this a while ago, I was like, if I get pregnant again, I'm either flying you out here or I'm heading to Utah because that is where I want to be. So these are the women that you want in your corner. But tell everybody where they can find you.
You can find us on Instagram at Davis County Midwives, and you can also swing by and say hi. We give high fives and hugs to people that we love. We're in Bountiful, Utah, our birth center.
Awesome. Well, thank you both for being here today.
If you loved what you heard today, the very best way to support this podcast and help other moms to find it is to leave a quick review. I read one at the beginning of the episodes, and I would love for yours to be next. And if you're ready for even more pregnancy, birth, and postpartum goodness, come join me in the My Essential Birth course at myessentialbirth.com, where I will hold your hand and walk you through pregnancy and birth step by step so you're totally prepared for a birth you'll love. See you next week.